All right, welcome. In this explainer, we are diving straight into a super high-yield review of elbow trauma. We're going to focus on the critical patterns that you absolutely need to nail for your exams, breaking down some of the most complex injuries around this really crucial joint. So before we get into the nitty-gritty of specific fractures, it's really important to remember why we treat these injuries so seriously. The elbow, you see, is an incredibly unforgiving joint. Think of it like a finely tuned machine. Its stability and its function depend on near-perfect alignment, and that's why getting an anatomical reduction is just paramount for a good outcome. Let's kick things off with a true orthopedic emergency, the dislocation of the elbow joint itself. Now, this isn't just a simple break. We're talking about a complete and catastrophic failure of the joint's architecture. What's absolutely critical to get here is the urgency. This is a time-sensitive injury where you have to reduce it and you have to do it fast. And it's almost always done under general anesthesia. You might ask why? Well, you need that patient's muscles to be completely relaxed so you can gently guide the joint back into place without causing even more damage to the cartilage or, the surrounding nerves and vessels. Okay, let's move on to our first key fracture pattern, and we're going to focus on the proximal radius. The radial head is so important for elbow stability, and let me tell you, fractures here are very rarely simple. So, when you're looking at one of these, the Mason and Johnson classification is basically your roadmap. It gives you a really logical progression of severity. It starts simple with a type 1, which is just a little non-displaced crack, and then it ramps all the way up to a type 4, where the radial head is completely shattered and the entire elbow is dislocated. And that brings us to a really key point. It's almost never just about the bone. Radial head fractures are notorious for being just one piece of a much larger, more complex puzzle, these named injury patterns that you have to be able to recognize. And you absolutely must know the Terrible Triad. Trust me, the name isn't an exaggeration at all. It perfectly describes the potential for really poor outcomes. This combination, the radial head fracture, the coronoid fracture, and the dislocation, it creates this profound instability that demands aggressive surgical management. Now, what's so great about this slide is how it contrasts two of these major injury complexes side by side. So notice, they both start with a radial head fracture. But look at the difference. The Terrible Triad keeps the instability right at the elbow. The Essex-Lopresti injury, on the other hand, involves a tear of that interosseous membrane, which means the instability shoots all the way down the forearm to the wrist, wrecking the distal radial ulnar joint. So how do we fix these? Well, the game plan is always tailored to how bad the fracture is. For simpler patterns, you can often fix the pieces with plates and screws. That's osteosynthesis. But for those highly comminuted fractures that are just shattered beyond repair, the options get more serious. You either remove the radial head completely, or, what's more common these days, you replace it with a metal prosthesis to maintain that crucial stability. Okay, next up, let's shift our focus over to the proximal ulna and talk about a very common fracture that goes right into the joint, the olecranon, the bony point of your elbow. The absolute key to understanding this fracture is the anatomy. You have the massive, powerful triceps muscle inserting directly onto the olecranon. So when that bone breaks, what does the triceps do? It contracts and almost always yanks that fragment proximally. This distraction at the fracture site is exactly why these injuries pretty much always need to be fixed surgically. And this is just a brilliant example of biomechanical engineering. It's the classic surgical fix called tension band wiring. By placing this figure of 8 wire in just the right way, that powerful pull of the triceps, which was pulling the fracture apart, gets cleverly converted into a compressive force that actually squeezes the fragments together and helps it heal. It's a fantastic trick, using anatomy to your advantage. All right, now we're moving up the arm to the distal humerus, and these are often incredibly complex fractures that go right into the joint, and they can be a real challenge to treat. This quote right here really gets to the heart of why these fractures are taken so seriously. Any step off, any gap in that smooth cartilage surface, even just a millimeter, can lead to debilitating post-traumatic arthritis down the line. So preserving that articular surface is everything. So, okay, you need to reconstruct that joint surface perfectly, but how do you even get in there to see it? I mean, the olecranon is sitting right in the way, blocking your view. Well, the solution is often to perform a controlled surgical cut of the olecranon itself. This allows the surgeon to actually flip the olecranon up and out of the way, along with the attached triceps muscle. It essentially opens the joint like a book, giving you a perfect, unobstructed view of the distal humerus so you can put it back together perfectly. Let's take a brief but really important detour into the pediatric population. You have to remember that in kids, the injury patterns around the elbow look distinctly different than in adults.
Now, we're not going to detail the treatment here, but you must recognize this as a very high-risk injury in children. Supracondylar fractures are absolutely notorious for their potential to cause severe neurovascular complications. We're talking damage to the brachial artery and the median nerve. It is a true pediatric orthopedic emergency.
Okay, that was a lot of information. So let's distill all of this down to the absolute must-know points for your exam. This is the stuff you need to walk away with. So here are the core concepts. 1. Elbow dislocation is an emergency. Get it reduced quickly under anesthesia. 2. Know your named injuries, the Terrible Triad and Essex-Lopresti. 3. Olecranon fractures get pulled apart by the triceps and fixed with a tension band. 4. Distal humerus fractures demand perfect reduction to prevent arthritis. And 5. Getting to that distal humerus often means cutting the olecranon. Master these points and you've got this topic down. And to finish, I want to leave you with a thought to take with you. You see, healing the bone is really only half the battle. The elbow is notoriously prone to getting stiff and even forming extra bone where it shouldn't after a major trauma. So when you think about everything we just covered, which one of these complex injuries do you think poses the biggest threat, not just to the bone, but to the long-term motion and function of that entire joint?